Good morning. Before I begin my remarks, I want to speak on behalf of all of us who are in Israel from other countries and express tremendous appreciation and thanks for the organizing committee for this conference, the hosts, the people who put on the banquet last night. The first day was just extraordinary, and the level of thought, the care, the attention, the professionalism of putting on this conference, IPRED II, and bringing people from around the world is absolutely extraordinary, and the music last night was fantastic. So thank you very much. Yesterday, we covered a wide range of topics. In the morning plenary, you heard a talk about policy, followed by a talk focused very much on the operations of the Israeli field hospital in Haiti. In the breakout sessions, we talked about everything from public communications to vaccine policy to search and rescue and a variety of issues. This morning, I would like to return to policy at the highest level, a nation's decision on how to spend money on preparedness and to public health emergencies as an opening point for our talk this morning. One of the most valuable exercises in a meeting like this is for each of us to bring our lessons to share with one another. Thank you. Okay. One of the most valuable lessons that we have is to share our experiences with one another. And so what I'd like to do this morning is to present my perspective on the United States response after September 11th and the Anthrax attacks, and how the policy decisions that led our government to spend dollars the way they have strengthened or done less than we had hoped in improving preparedness in the United States. Before I do that, I want to briefly explain what RAND is. Because for an organization that's existed for over 50 years, we're not as well known as many of the United States' great universities. RAND is an independent, non-profit, non-governmental research organization dedicated to objective policy analysis. We try to approach questions with an open mind, a skeptical sense, to help inform policymakers not only in the United States but around the world. We operate a graduate program in public policy, a PhD program, but have no other academic offerings. We're not a university, we're not a management consultant, but we have qualities of both. And over the last decade in particular, under the leadership of my predecessor, Dr. Murray, other colleagues at RAND, and more recently myself, we have done a lot of work in public health and emergency preparedness. We helped develop performance measures for the U.S. Strategic National Stockpile. We developed tools for estimating lab capacity both internationally and in the United States. We systematically assessed global influenza surveillance and U.S. pandemic planning. We conducted an in-depth analysis of disaster responses in 13 disasters in 11 countries to see what we can learn from the best practices of other countries to apply to the United States. We assessed the U.S. response to Katrina and 2009 H1N1. I'll comment on that in a moment. We helped the U.S. government craft its national health security strategy. And we are completing a very ambitious project to assemble and review all of the research evidence on allocating resources, scarce healthcare resources in a mass casualty event, to see what does the science tell us, what do we know today about how to do that. Before I give a brief review, I want to point out there are some obvious differences between my country and our host country. The first, obviously, is size. Size not only in geography, but size in terms of population. The United States is a much larger country in terms of people. It is also an extremely complex public health and healthcare system. You have 4 health plans in Israel. We have over 1,300 in the United States, a mix of public and private, government and non-government. You provide health insurance coverage to all of your citizens. We don't. And so the question often asked in the United States, does this patient have health insurance, isn't even relevant in Israel. Good for you. Too bad for us. We also have a huge number of individuals, agencies, and organizations involved in police, fire, emergency medical services, and that complexity is a tremendous challenge to us as we try to fashion effective strategies for preparedness. We also have a very different approach to policy making. In the United States, when our Congress passes a law, our agency heads, the heads of our ministries, are obliged to follow Congress's direction and pursue those policies. That insight is relevant to what I'm about to discuss. Before September 11th, before the terrorist attacks that brought down the Twin Towers in New York City, and our Pentagon was severely damaged with the loss of great numbers of people, our nation had become complacent about public health. The accomplishments of a century, vaccines, sanitation, many of the approaches that improved our food and drugs had done such a good job that the public had come to take public health for granted, did not support it as well, and for a number of years public health in the United States had been in decline. In 1988, our Institute of Medicine looked at the American public health system and said it is in disarray. 13 years later, they revisited this question and said no progress has been made. There was inadequate funding, gaps in workforce and lab capacity, and very mixed progress on many of the key public health priorities in the United States. On September 11th, that insight changed drastically. Suddenly, we realized how badly we needed an effective public health and healthcare system, and there was still smoke rising from the rubble pile in New York City when envelopes of anthrax were discovered in the office of one of the leaders of our United States Senate, which absolutely terrified our Congress. It was a personal attack on our U.S. Congress, and they responded accordingly. 9/11, the crashing of the airplanes into those buildings prompted a massive United States response. Militarily, first in Afghanistan, later in Iraq and Pakistan, and a commitment of over $2.6 trillion of military action over the next 10 years. It also prompted a massive deployment of dollars and resources for homeland security, airport security, intelligence. That's where most of the focus following the 9/11 attacks were made. The anthrax attacks had a far more powerful effect on public health systems and preparedness. In fact, fear of bioterrorism, fear of anthrax, fear of smallpox, fear of an enemy attacking us with biological agents drove a lot of Congress's policymaking and decisions about allocating resources and spending. And over the next 10 years, it's estimated that our Congress spent at least $60 billion US primarily on biodefense. Most of that funding, as one would expect, went to our health sector. Over $4.4 billion US in 2012 alone are being allocated to biodefense. So this continues to be a major focus for U.S. preparedness spending. Over the decade, over the 10 years after September 11th, different programs in our health sector got different amounts of money. Early on, there was a huge push. This yellow line shows a huge allocation of dollars to our strategic national stockpile, vaccines and drugs for certain key biological threats. There was also a huge push of money to help strengthen state and federal public health preparedness, especially in biodefense. Within a couple of years, government spending to help improve and strengthen hospital capacity for biological attack also began to increase. And over the decade, there were major programs for anthrax vaccine development and smallpox vaccine production that were also funded, and then those dollar amounts declined. There were three major programs then and now that were the signature programs for biodefense. Each of them had a very good purpose in mind. None of them had been as effective as we hoped. The first of these was BioWatch. BioWatch was designed to set up environmental sensors in 30 major cities in the U.S. to sniff the air and hopefully detect aerosolized anthrax or some other biological agent. I was on a committee for our Institute of Medicine, part of our National Academy of Sciences, that reviewed this program, and we noted that while a great deal of money and effort had been put to deploy these sensors, there were relatively few in any city. The wind had to be blowing the right way. A terrorist had to release an aerosolized agent that the sensors were designed to detect. And even then, what we had noticed over many years were that when these sensors set off an alarm, it was typically an environmental contaminant. And so over a number of years, this cycle of an alarm meeting, is it something, is it not, had created almost a response fatigue. Some of you may remember the story of the boy who cried wolf. In this case, the alarms kept going off, and after a while, people were like, not going to worry about it. Whereas those responses had been an opportunity to learn how to come together, problem solve, and make decisions. Instead, it was creating a sense of fatigue, particularly with local public health authorities and federal response officials. So there is now recommendations to, if we continue this program, use better sensing technology, more accurate response, but also learn from these responses so they become almost no-notice drills, rather than an exercise in fatigue. Another program was Biodefense, an equal commitment to syndromic surveillance, analyzing huge reams of data to look for signals that a bioterror attack might be beginning. Some of us call this a full employment program for epidemiologists. But in fact, this again, great idea, but in execution has not proven to be as effective or as useful yet as we would hope it to be. It seems to be more helpful at tracking an evolving outbreak, not so helpful at picking one up as early as we would like. The third program is BioShield, and this is a program that has acquired and deployed medical countermeasures for the Strategic National Stockpile and other threats. Early on, anthrax vaccine was a major focus. In 2006, the Department of Health and Human Services terminated a contract for a new vaccine because of problems with production development. So the technical aspects of making our biomedical industry come up with novel strategies and novel products has been very challenging. And a great deal of issues of logistics and stockpile management have created real challenges with this program as well. But the point is that this focus, these major spending programs, also had unintended consequences. And as policymakers and as experts in preparedness, we always need to think not only about what do we hope to accomplish, but what might we cause as a complication. And one consequence of this focus on biodefense were the hidden costs. In the case of health departments, a lot of federal money for bioterrorism meant less federal money for other aspects of public health. When money was sent to state and local health departments early on, Congress said, don't you dare spend that money on anything other than biodefense. And so public health departments' hands were tied, and they had to keep this money categorically for the threat of bioterrorism instead of using it to broadly strengthen and improve their capabilities and capacity. Staff had to be reassigned to biodefense programs away from other core public health functions. And while there was evidence of improvements in biodefense capability, there was elimination or reduction in core capacity and capabilities in other important public health functions as a result of this flow of money and its very narrow focus of its deployment. Just as important, we were not paying as much attention to other major population health threats. Hurricanes, tornadoes, earthquakes, terrorist attacks involving bombings and other forms of attacks such as chemical or radiological weapons. While there were programs looking at these, they received far less attention, far less funding, far less focus than bio threats alone did. And in fact, in the 10 years that followed September 11th and Anthrax, all of the major events in the United States have had natural causes. SARS outbreak, the fear and threat of avian influenza, Hurricane Katrina, the H1N1 pandemic. In 2005, Hurricane Katrina was as great a shock to our country in many respects as September 11th had been. Although it was a natural disaster, it revealed tremendous problems with our ability to coordinate with one another, our federal government with state government, with local governments, volunteers and public officials, crisis decision-making, command and control. Everything seemed to break down, especially in the city of New Orleans. And this created a lot of soul-searching, a major focus on an after-action report, which was badly needed, and real decisive change in improving leadership, creating incident command systems, improving accountability, improving decision-making. By 2009, we began to see evidence of real progress. Our response to the 2009 H1N1 pandemic was substantially better. Granted, it was a very different kind of disaster, a very different kind of threat, but in many respects, our public health system at the federal, state, and local level performed much better. Advanced planning and practice had laid the foundation for an effective response. Federal labs quickly identified and characterized the virus. Physician guidance was generally quite good, so doctors knew what to do and what not to do. Antiviral stocks for adults were adequate, not so true for children. A vaccine was produced in record time, but as Dr. Lurie pointed out yesterday, not fast enough. Our technology for vaccine production is still behind where it needs to be, and the pipeline process is still too slow. And public communication was substantially better, but we still had the vaccine critics and naysayers that created some sense of doubt and fear in the public, a topic commented at this meeting yesterday around the world. But over the decade, we've learned. We have thought about this, we have taken stock as each of these events have unfolded, and the United States government, the United States people are beginning to systematically get our act together in a very different way than where we started in the early months and years of trauma following September 11th and Anthrax. We have still kept a focus on biodefense and bioterrorism, but we are now far more interested in the overall capabilities of our response system, far more interested in the building blocks, the Legos that Dr. Lurie talked about yesterday. In pandemic response, in decision support, in command and control, in having the resources and capabilities to be flexible and meet different threats. And this culminated with the creation of this National Health Security Strategy that Dr. Lurie described to you yesterday. The NHSS, as we call it, is built not to focus on a single threat, aerosolized anthrax, smallpox, but a range of capabilities that can be brought to bear, adapted, or modified to address a much wider range of population and public health threats. And while we're making progress, we, like all of you, face real challenges that are still in front of us and that we must overcome. In 2012 in the United States, we recognized that teamwork is essential, but we are still struggling with both the size and the complexity of American society, federal, state, local, private, business, non-governmental, charitable organizations, and how to better engage our individual citizens, not simply as cooperative followers of orders, but as rescuers of themselves and their neighbors, the true first responders in a disaster. Second, the National Health Security Strategy recognizes that the foundation of any response, whether it's to bioterrorism or a natural disaster, is a strong public health system with strong core components and an equally strong and flexible healthcare system, including emergency care. To that end, we have an enormous challenge in the fact that while we have very sophisticated hospitals with advanced equipment and highly trained physicians and nurses, we have very little surge capacity in the United States. We try to run our hospitals the way we try to run our airlines. We want to fill every seat with a paying customer. That doesn't leave us much flexibility when we have a lot of casualties from a sudden event or from a pandemic. We have an even greater problem of overcrowding of our emergency rooms. And as Dr. Kobe Pellig wrote with me a couple of years ago, in the U.S., unlike Israel, you don't let your emergency departments gridlock with patients. We routinely do in the United States. We would rather have an ER full of patients and empty hallways upstairs than an empty ER ready to receive sudden surge of casualties. That creates real logistical challenges for us. To this end, we are currently developing a tool at RAND to help American hospitals learn and better manage a sudden surge of casualties, based loosely on the approach that Israeli hospitals routinely practice, and many of us will see tomorrow in Haifa. Another challenge is, how do we better promote recovery? How do we help cities rebound and strengthen following an event? This is another area where I think we have real opportunities to do better. And perhaps our greatest challenge, as it was 10 years ago, is once again we're in a cycle of declining funding for public health, especially. The global recession has had an immense impact in the United States. While we are no longer officially in recession, our local, state, and federal governments have very tight budgets, and public health is not as popular, it's not as sexy, it's not as politically connected. And so over 16,000 state health workers have lost their jobs. Local health departments have cut nearly 30,000 jobs. We need those people in a disease outbreak, in a catastrophic flood, following an earthquake, to meet any public health threat. And so this is having a real impact on our core capacity. And yes, even a decade and $600 billion of spending later, $60 billion of spending later on biodefense, we still aren't where we need to be or want to be, even for meeting bioterrorism. In part because we don't have the core strengths and capabilities in place in public health and healthcare to back and buttress the biotechnology capabilities we are seeking to better defend ourselves and the world from biological threats. So this is also an ongoing challenge for us. In closing, I want to offer some thoughts in coming up and confessing to you that despite all of the money, despite some of the most gifted and dedicated scientists and clinicians and public health care experts in the world, despite a clear sense of the challenges that we face as a country, we haven't done as well over the last 10 years as we would hope, although we are better than we were 10 years ago in preparedness, and we are clearly moving in the right direction now with a national health security strategy and leadership that understands the value of these components. We also have to learn from experience and share our experiences with you as you do with us. In the first years following September 11th, the U.S. government's very narrow focus on bioterrorism probably left us less prepared rather than more prepared for other forms of mass casualty events, like a catastrophic hurricane. But more recently, we have begun to shift to a more broad-based, all-hazards approach built on capabilities, represented in our National Health Security Strategy. Biotechnology is useful, but it is not enough. You still need people, and you still need systems and capabilities to be able to manage information, make decisions, and execute properly. Topics you heard discussed yesterday, and you'll hear commented upon today. Preparedness depends on a strong foundation of public health systems and properly responsive healthcare systems. You can't build a biodefense structure in thin air. It has to be grounded on core strengths in a healthcare system and public health. And finally, as I have tried to do with you this morning, in order for us to strengthen global health security, in order for us to be a more prepared world, working with each other and supporting one another, we must learn from our experiences, both domestic and international, and share that hard-won knowledge with each other, so that together we will be wiser, we will be more effective, and we can do a better job of protecting the health of our nations and protecting the health of the world. I thank you for your attention. I look forward to working with you for the rest of this meeting.